Hello, and welcome to the Cabell Huntington Hospital Reverse the Cycle Nurse Training. At the conclusion of this training, participants will understand the evidence-based SBIRT model, understand all components of the Reverse the Cycle model in your hospital, understand how Reverse the Cycle is implemented at the hospital, and understand your role as a nurse within the program, including screening and the COWS, otherwise known as the Clinical Opiate Withdrawal Scale. Let's begin by talking about substance use, what we know to be a national public health crisis. There were approximately 21.6 million Americans who needed substance use treatment in 2019. That's about 1 in 15 people. Unfortunately, only about 2.6 million of those Americans received treatment, equaling about 12%. In 2019, there were also 35.8 million Americans aged 12 or older who reported current or past month illicit substance use. Drug overdose also continues to be the #1 cause of injury-related deaths in the United States. As we look at opioids specifically and their impact on hospitals, each year approximately 20 million individuals visit emergency departments for illness or injury. And what we know is that about 15 to 20% of those individuals would screen positive for having a substance use disorder. And for trauma-related visits, that number increases to 25 to 50%. As we look at the data related to opioid-related inpatient stays, in 2017, West Virginia had a rate of more than 350 opioid-related inpatient stays per 100,000 people. And as we look at the national rate for drug overdose deaths, according to the CDC, there were 67,367 drug overdose deaths that were reported in 2018. Of those, 46,802 could be attributed to opioid overdoses specifically. It's about 70% of those deaths. And West Virginia had the highest among all of the states for opioid overdose deaths, with about 51.5 deaths per 100,000 people as we're looking at the same period. And as we look more currently at the data and we think about what the rates are now, we can see that unfortunately those percentages are only predicted to go up. And so it's really important to look at the options to begin to address these alarming trends. As we look here at the West Virginia opioid overdose deaths, for the period of 1999 through 2018, we can see they were steadily increasing over time. In 2017 to 2018, there was a decrease overall, but still a significant number of West Virginia residents, 702 in particular, died as a result of an opioid overdose. 551 of those deaths could be attributed to synthetic opioids, like illicitly manufactured fentanyl, while 234 could be attributed to prescription opioids, while 195 could be attributed to heroin specifically. Cabell County and their drug overdose deaths in particular, in 2018, Cabell witnessed 438 fatal overdoses, and 393 of those overdoses were opioid related. The reverse cycle model is a comprehensive hospital substance use response program. And Mosaic Group and the state of West Virginia recognize the need for a more powerful response to help the patients that are being seen across the state. Reverse the cycle includes screening, brief intervention, and referral to treatment, otherwise known as SBIRT, as well as the Overdose Survivors Outreach Program, known as OSOP, and finally, medication-assisted treatment initiation in the emergency department. So what is SBIRT? SBIRT begins with screening, which, as it says here, is the application of a simple test to determine if a patient is at risk for or may have an alcohol or other substance use disorder. So it's using a validated tool to determine what a patient's risk level may be based on their reported use. From there, it's a brief intervention, which is an opportunity to talk to a patient about their screening results, provide information on safe use, and really help to determine what a patient's readiness for change may be. And then, when appropriate for patients with positive results and a readiness for change, it's an opportunity to make a referral for a more in-depth assessment and/or treatment. So how will Reverse the Cycle be administered at Cabell Huntington? It will begin with the peer recovery coach model. And so the peer recovery coach integrates individuals in long-term recovery into your workflow. And so if we look here at the bottom, you will begin with all of your emergency department patients age 18 and older being screened. From there, there will be an alert through the medical team to the peer recovery coach, who will then review the screening results, discuss any information regarding the patient's case with the nurse, and then the peer recovery coach will provide that brief intervention to those patients who have been identified. From there, the peer recovery coach will develop a plan with the patient, schedules any necessary appointments, and helps the patient connect with those appointments. At Cabell Huntington, the screening protocol again says that all emergency department patients age 18 and older are going to be screened by nursing during the nursing assessment. Nurses should open the primary assessment, then go to screenings, and then go to adult SBIRT screening. These tools are located within Cerner, and the screening consists of the Audit C, which is a 3-question validated tool to identify alcohol use, as well as 2 drug questions to review the patient's illicit substance use as well as prescription drug misuse. The Audit C, again, the alcohol screening with a score of 7 or greater or an answer of yes to either of the drug questions would be considered a positive screening. There are some times, however, when it would not be possible to screen a patient. And in those instances, it would be the opportunity to use one of the appropriate exclusion criteria within the documentation. In specific instances, if the patient is intoxicated or is a suspected opioid overdose or just a general overdose, if in some cases maybe there's a provider request or an acute psychiatric illness, if the patient is less than 18 years of age, and in slim cases, the patient potentially refuses to answer the question, may be too ill or critically ill in this case, or is nonverbal. In those instances, the use of the exclusion criteria will allow you to skip the screening questions, indicating that because of these reasons, the patient is not appropriate for screening. Depending on which exclusion criteria is selected, determines the next steps. Intoxication, suspected opioid overdose, or suspected overdose non-opioid, as well as provider request, will still trigger a positive result to the peer recovery coach, while the other options will not. Here we do have a screenshot of your SBIRT screening. So you can see from this, it does begin by identifying whether or not the patient meets one of the exclusion criteria. If they meet none, you will simply check that and then go on to the boxes below to identify if the patient used any recreational drugs, yes or no. Did the patient misuse any prescribed medication, yes or no. It is very important that if the patient does identify any recreational drug use or prescription drug misuse, then indicate within that next box below which substances the patient is using. That's used for a number of reasons. Number one, it allows the clinical team to continue to evaluate what the patient reports to use, but it also helps the peer recovery coach plan for their interaction with the patient and to conduct any necessary prioritization that may occur based on the number of patients that are present and have a positive at one time. You'll see at the bottom of the screen, there are some instructions here because we do want to make sure that you are reading the questions as they are asked. These are validated questions. And so in order to obtain the most accurate results, it's important that we don't put our own spin. So for instance, you would want to ask the patient, how often do you have a drink containing alcohol? And then you want to provide them with the potential answers. So never, monthly or less, 2 to 4 times a month, 2 to 3 times a month, or 4 or more times a week. If the patient responds never, then it is not necessary to ask the other 2 questions because it's not necessary to ask how much somebody drinks when they drink if they never drink. However, if they respond to anything other than never, you do want to proceed and ask the remaining 2 Audit C questions. Again, reading them as they are worded on here. Just to continue on with what then happens next. So once the screening has been completed, if it is negative result, then there is no additional action necessary. Unless for some reason you have reason to believe or be concerned about the patient's behavior. In that instance, you could go back and click provide a request under the exclusion criteria. Otherwise, if the patient has a positive result, there will be a trigger on the track board for notification to the peer recovery coach so that they can see that a patient in need of a brief intervention is present within the department. The on-duty peer recovery coach will conduct a brief intervention and develop a plan with the patient. In instances when a referral to treatment is appropriate, the peer recovery coach will help make those referrals to the appropriate community-based program. Just a little bit about those peer recovery coaches that are joining your team or a part of your team. Peer recovery coaches are individuals in long-term recovery from substance use disorders, and they've been trained in motivational interviewing and other skills to really use their lived experience to help patients that are in active addiction. Your emergency department will be onboarding 3 full-time peer recovery coaches, as well as 1 overdose survivor outreach peer recovery coach who is more community-based. And they have been employed by Recovery Point, and they will be housed within your emergency department. Again, that ED-based peer, they are responsible for providing brief interventions and referrals to treatment for those patients that are identified as having risky alcohol or other drug use, while the overdose survivors outreach peer or OSAP will provide intensive outreach and follow-up in the community for patients who came to the ED as a result of an overdose. Next, we're going to begin to talk about MAT initiation in the emergency department and fast track referrals. MAT initiation, MAT stands for medication assisted treatment. And patients in the ED who begin or are already experiencing opioid withdrawal can receive an 8x2 milligram dose of buprenorphine naloxone, really allowing them to begin to feel better while they're receiving care within your department. And when a patient feels better and is no longer in the middle of experiencing active withdrawal, they really have the opportunity to participate in their care. They're less likely to leave via AMA, and they are going to be more inclined to participate in their discharge planning and really understand the plans that are being made with their involvement. It is also helpful for a patient who is opioid using to, again, have that MAT initiation and to begin to feel better, because then they are going to also be less likely to use illicit substances when they're discharged from your department and before transitioning to care and community-based treatment. So we know that patients who do receive a dose in the ED and avoid illicit use are more likely to engage in treatment within the next 24-hour period. And patients that are engaged in recovery are more likely to comply with their follow-up health care and less likely to revisit the emergency department for ongoing care. At Cabell Huntington, your peer recovery coach will confirm that the patient is motivated for treatment and willing to attend treatment the following day. The peer recovery coach will then refer the patient to the provider for MAT initiation. The provider will then determine if the patient is approved for the buprenorphine naloxone administration in the ED. That includes ensuring that the patient meets the DSM-5 criteria for an opioid use disorder, as well as reviewing to determine if the patient meets any of the cautionary or exclusionary criteria that would be a contraindication for use of buprenorphine. The cautionary criteria include prescribed or illicit benzodiazepine use, pregnancy, clinical evidence of liver disease. While exclusionary criteria would be the patient is appropriately taking any prescribed long-acting opioids, is experiencing acute psychiatric illness, or has a true allergy to buprenorphine or naloxone. If the patient is clinically appropriate, the provider will ask the nurse to complete the Clinical Opiate Withdrawal Scale with the patient. The nurse will complete the Clinical Opiate Withdrawal Scale, and if the patient scores an 8 or above on the COWS, the nurse will notify the provider verbally of the COWS score. The provider will then place an order for the dose of buprenorphine naloxone, which will then be administered to the patient while they are in the department. Pregnant patients may also be dosed while they are in the department and will be prescribed an 8 milligram dose of buprenorphine only, as opposed to the combination product of buprenorphine naloxone. As a nurse within the department, your role is to administer the medication and observe that it is taken in the manner in which the patient has been educated to ensure that the patient takes it properly and with the goal of receiving the full benefit. So the Clinical Opiate Withdrawal Scale, again, the COWS, is a method of recording scores for various symptoms of opiate withdrawal. It allows for you to determine through that assessment the level of withdrawal for a patient that is using opiates, and it is frequently used in healthcare settings for patients who have received opiates for treatment of pain and is potentially showing adverse signs of opiate withdrawal as a subsequent result. Reviewing any clinical needs for induction on buprenorphine products, the COWS is a preferred tool. And the sum of the numbers based on each of the questions determines the level of opiate withdrawal and can help determine the next course of action. Nursing will be notified if the COWS needs to be completed for consideration of induction. So the COWS has been built into Cerner, and there are two pathways to get there. So you can receive the task if it's been ordered and access it there, but it's also available in ad hoc forms as COWS, C-O-W-S. And here on this screen, we can see, although it's a bit small, there are a number of questions. And so for each item, you are going to choose the one that best describes the patient's signs or symptoms, and you are going to rate on just the apparent relationship to opiate withdrawal. So for example, if the heart rate is increased because the patient was just jogging prior to the assessment, the increased pulse rate would not add to the score. So you will be looking at the pulse, you will be looking at the patient's body temperature, you will be looking at pupil size as an example, if the patient is having any pain, if they are reporting any gastrointestinal symptoms, any tremors within their hands, and then each of these will, based on your entry, each of these will provide a total score for each of the 11 items noted here on your screen. So just a little bit about how buprenorphine works. Buprenorphine is a partial agonist, and so it does provide a ceiling effect for opioids, meaning that, if a patient attempts to take more, they're only going to receive, or achieve a certain level of effect. And as a partial agonist, it does have a high affinity for the opioid receptors in the brain, but a slower dissociation from those opioid receptors when compared to other substances, and in particular when you think of illicit opiate substances like heroin. In the primary formulation that you will be using, it is formulated with naloxone. So if the patient were to attempt to use the medication in a way that it was not intended, the naloxone would block the opioid effect. But if the patient takes the medication as intended, and in this case as observed by you as a nurse, then it does not activate. This is just a slide to help demonstrate the impact and effect that buprenorphine can have as we look at. So as you can see here, we have that opioid receptor. If we look in that top left-hand, the little picture in the top left-hand corner, and we can see there the patient is experiencing withdrawal and pain, and that receptor is empty. And so the green figure represents the opioid, while the little yellow dots represent the buprenorphine. Of course, the green is a perfect fit. And so in those cases, the patient would experience the maximum opioid effects. They'd have no withdrawal or pain, but they would also have those euphoric opioid effects, as well as the risks that come along with opioid use. The buprenorphine, it's an imperfect fit, so it is, going to respond and partially activate those opioid receptors, but it's also going to block any additional opioid use that the patient may attempt while it's still present in the body. And here's some brief patient education that we want you to think about to ensure that as you are dosing the patient with the buprenorphine and naloxone prior, while they're in your department, they're aware of this prior to taking the medication. So number one, you do want the patient to start with a moist mouth. These are sublingual tablets, and so they do need to dissolve under the tongue. And of course, starting with a moist mouth really helps to create that environment. However, you do want the patient to avoid acidic drinks like coffee or fruit juice, which I know can sometimes be prevalent within the department. You want them to drink, like water or soda, things like that. And the patient shouldn't be smoking immediately before or after taking the medication. We don't want them to talk during the administration. And we also want them to keep the tablet under their tongue. Don't chew it, don't swallow it. They will not then achieve the maximum effects, and they may still continue to feel sick. So although they may be inclined to try to get it in faster, it's really best if they wait, again, until it dissolves. This is just a screenshot of the MAT order set that the provider will be completing. As indicated earlier, there's a number of factors that they are looking for. And so this is all under the MAT induction folder. Within there, you can see that there's the CALS assessment as well as the order set. There is this cautionary criteria again, so we do see this red to really just advise that if certain criteria have not been met or are met, for instance, if there is concern of liver disease or current uncontrolled psychiatric disease, any specific allergies, or CALS scores less than 8, that the medication should not be ordered. And as we think to work to prevent any precipitated withdrawal that the patient may have, withdrawal is really more likely when there is a high level of physical dependence, while having a short time since last opioid use. If we think about short-term versus long-term long-acting opioids, if you want to think about heroin versus methadone as an example, as well as if the initial dose of buprenorphine is too high. And so in this case, and within this program, one of the primary preventions is to administer the first dose of buprenorphine when the objective signs of withdrawal are present, which is why the use of the CALS is really so critical, as is, the other parts of the assessment process to really understand what opioids the patient is taking. So as part of this MAT initiation process, there will be a fast-track referral to a community-based provider within 24 hours so that the patient can continue their dosing. And a fast track provider is really just a network of community treatment providers that are ready and willing to accept MAT patients within same day or next day for continued maintenance therapy. The peer recovery coach is responsible for following the site-specific protocols for each of those community programs to ensure that a patient can be referred, in some cases, any day or any hour. And the peer recovery coach will not recommend a patient to be dosed unless the patient has confirmed they are willing and able to attend that treatment appointment. So let's next talk about the Overdose Survivors Outreach Program, again known as OSOP. In this case, the patient is seen within the emergency department by an opioid overdose by one of the ED peer recovery coaches. That peer recovery coach will work quickly with the patient to provide overdose prevention education, discuss any risks of use after naloxone administration, and when possible, introducing not just the OSOP program, conducting an introduction to the OSOP peer recovery coach. The OSOP peer recovery coach will then, within 24 hours, connect the patient with recovery support services, help connect to treatment programs if that's something the patient is interested in, and really help to coordinate care and services to prevent subsequent overdoses and save the patient's life. The OSOP peer recovery coach has the ability to work with the patient for up to 90 days discharge from your emergency department. So just in summary of the reverse the cycle model, including SBIRT, MAT in the ED, and OSOP, nursing staff will screen all patients age 18 years and older during the ED nursing assessment. Patients that screen positive are then referred to a peer recovery coach. The peer recovery coach will provide a brief intervention and develop a plan with the patient that may include MAT initiation in the ED. There will then be the documentation of the brief intervention and plans for follow-up, and when appropriate, the patient may be referred to OSOP if they have experienced an opioid overdose. The patient will be provided with a referral when appropriate, and follow-up calls will be scheduled as appropriate. Thank you for listening to this presentation about the Reverse the Cycle program at Cabell Huntington Hospital. Should you have any questions, please feel free to reach out to Marla Oros, President of Mosaic Group, or Tiffany Latham, the Senior Behavioral Health Consultant who has been assigned to work with your site. Thank you.